Hello, and welcome to episode 2. Now, before we get into the bones of this topic, I want to be very clear about what this episode is really about and why we are spending an entire episode talking about scans. Scans, on the whole, are powerful tools, very powerful medical tools, and they save lives. They guide surgery, they help identify serious disease, and they're absolutely essential in many situations. But the types of scans we're talking about today are scans of joints, muscles, tendons, and the spine. Okay, and these are the scans that are generally used to look for a source of pain. So we're not talking about scans of organs or brains or medical scans. This is purely muscles, joints, tendons, the spine, discs, nerves, things like that. Okay. Now, we described in the first episode what normal, predictable pain is, how it works, and how it behaves in relation to damage in the body. When it comes to scans, however, we need to remember that they are not pain detectors. Scans don't show pain. As described previously, pain is a message sent from our brains to an area of the body, usually in relation to damage in that area of the body. Now, at times there may be pain where it comes on suddenly, or there is trauma involved, or pain is persisting past when we would normally expect it to be there. And we as humans or clinicians will often look to scans to try and assess the true nature of the pain and the damage that has been caused. But here lies the problem. Can we trust that any damage or changes that we see on the scan accurately reflect the true source of the pain? And this is one of the key points we want to discuss. And this is a really important issue because when we go on to talk about more persistent pain in the next episode, we often find that people in these cases turn to scans to try and make sense of their symptoms. But the problem with that is a scan simply shows what something looks like. How do we tell if what we're seeing is relevant or it's just a normal abnormality? Now, when is it appropriate to scan? And when does a scan simply confuse the matter or potentially award a patient a diagnosis that isn't really relevant? And a diagnosis that can significantly change how they perceive themselves and how they perceive the injury. And it's really important that patients have context on when a scan is required and when it's not. Now, there is another important focus on today's episode, and this is in relation to how scans are interpreted. Because images have to be read and reports have to be written, usually by a radiologist. Those reports then go and they are interpreted again by a clinician, so be it a GP, a consultant, a physio. Now, there are many factors that affect how it is interpreted and what happens if two clinicians look at the same report and reach very different conclusions about what's relevant and what's not. So when we talk about scans, we're not just talking about the machines that capture the image, we're talking about the human that interprets them and how this interpretation can have profound effects on patient outcome. Now, before we jump into some of the research behind this, I want to briefly talk the different scans and what they're actually designed to do, just so we're all very, very clear on what they do. So obviously the basic one that everyone's familiar with is an X-ray, and it's your most basic form of imaging. Now, it uses radiation to create an image of the more dense structures in the body, mainly bone. Okay, and as you're no doubt aware, very good at showing things like fractures, dislocations, and more kind of advanced arthritis changes within the body. Now, despite what's sometimes indicated, they're very poor at showing tissues that are actually what we most commonly associate with generating pain, so such as muscles, ligaments, discs, and nerves. So an X-ray can tell us a lot about the skeleton, but relatively little about many of the structures that people assume are causing their pain. Moving on to a CT scan, essentially is a very advanced X-ray. So instead of one flat image, it takes a lot of X-ray slices and it builds them into a detailed kind of cross-section. So essentially what it is, it's like a three-dimensional version of a standard X-ray. Now, a CT scan shows bone in much greater detail than a standard X-ray and are often used when fractures are a bit more complex or when there's a trauma involved or when speed is important. Now, it still involves radiation, a lot more radiation than an X-ray, and they are still far better for bone than they are for, say, soft tissue structures like muscles and tendons. Now, a CT scan is mainly used to get a fast, detailed look inside the body and to check for things like broken bones, for bleeding, signs of infection or inflammation, and problems that affect the internal organs such as the lungs and the liver and the bowel. Okay, and that would be the main aim of a CT scan, or the main use of a CT scan. An MRI scan now is very different. An MRI scan doesn't use radiation, so it uses magnetic fields, and we're all familiar with this. It's that tunnel, the one where we go in through the tunnel, and takes very detailed images of soft tissue. So an MRI is very good at showing discs and nerves, the spinal cord, muscles and ligaments, and changes within the bone itself. Now, because an MRI shows so much detail, it's also very sensitive, and that's one of its strengths. But it can also be a drawback, because they're so good at picking up things that they often find small changes that are kind of a normal part of aging and everyday use of our bodies. And many of these changes are common in people who have no pain at all. You can think of it like zooming in very closely on a high resolution photo. The more you zoom in, the more tiny marks and imperfections that you'll see. And seeing something on an MRI doesn't automatically mean that that's the cause of the person's symptoms. So when people say, oh, so an MRI is the best scan, what they usually mean is an MRI shows the most detail. So more detail doesn't automatically mean more answers, but it does mean more information. And that information still has to be interpreted. And then finally, we have ultrasounds. Now, ultrasounds, obviously, as the name suggests, they use sound waves rather than radiation. And they look at kind of muscles, tendons and ligaments and kind of fluid around joints as well. One of the main advantages of an ultrasound is that they show structures in real time. And what we mean by this is it can show how structures move while the scan is actually on you. So it's very useful for assessing things like gliding of tendons or muscle contractions, or whether or not a structure is being irritated by certain movements. So a shoulder ultrasound is a very good example of how we can actually see a shoulder move in real time and see what's happening to the structures at that time. So it's quick, widely available, and can be used to guide injections as well, and or for certain procedures as well. So how as clinicians do we decide which scan, if any, is actually appropriate? And it comes down to a question of what we're trying to answer. So if there's been a significant fall or trauma and we're concerned about a fracture, an X-ray or CT scan might be appropriate in that case. If, however, symptoms suggest maybe nerve involvement in the spine or other parts of the body, an MRI is usually a better choice. And if there are red flags, so these would be suggestions of something sinister or serious going on, like an infection, inflammatory disease or a tumour, an MRI again is often preferred. And if we're more concerned about moving joints, so particularly the shoulder again or the knee, an ultrasound can be useful because it allows us to assess structures in real time and as the joint moves. The scan is chosen to match the problem, not the other way around. And we hear this all the time in the clinic. And I mean, even recently I was referring a patient for a shoulder ultrasound, and I was asked by the patient, is this the best scan? And I tried to explain to them that it's the best scan for this particular issue, to which then they immediately replied that, well, would an MRI be better? Because I'm happy to pay for it if it is. And I had to take a lot of time to explain to them just what we've discussed so far in the podcast. And even still, I'm not sure it fully hit home. And this is the issue with increased scanning and increased access to scanning, is that people often feel that the likes of an MRI is more appropriate or is a better scan, whereas it's our job to explain when a particular scan is actually warranted and when it's not. And the scan has to match what we're actually looking to find. In fact, I mean, when we talk about access to medical imaging, this has increased dramatically over the past few decades, and particularly in the likes of UK and Europe and certainly in the USA as well. Scans are easier to obtain than they ever were, and also the opportunity to self-refer for scans is now greater than ever. Now, on the surface, that might sound positive, so more technology, faster access to it, and therefore more answers. But when we look at the data, it paints a very, very different picture. So despite the fact there's been large increases in imaging rates, levels of persistent musculoskeletal pain and disability haven't fallen at all. So we're doing more scans than we ever did, but society isn't becoming less burdened by pain as a result. Now, large research studies consistently show that routine imaging for common musculoskeletal problems don't actually improve outcomes, particularly for conditions such as low back pain or knee pain or shoulder pain. Now, what this means in lay terms, and I suppose in logical terms really, is that even though we're scanning more people and we're scanning people earlier, people's pain doesn't actually reduce quicker. They aren't recovering quicker. They can't function any better. Now, this may appear logical on the surface. A scan only shows a picture. It's not a form of treatment. So therefore, it doesn't actually reduce pain. It just gives information. Now, people may argue that, well, it identifies what the problem is, so therefore it can be treated. But this is the whole point of the podcast, to show that that's not always the case. In many cases, they simply identify findings that are also present in a large number of people that don't have any pain. And this is why clinical guidelines around the world advise against routine imaging or scans for back pain, for instance, unless there's a very clear reason to do so or a very clear question to answer. Now, just on that last point, we, I suppose, need to define what routine scans are. So what, in plain terms, what does a routine scan mean? So when we talk about routine scans, we mean scans that are done without a specific clinical warning sign. Okay, so there's no significant trauma, there's no suspicion of a fracture, an infection, a cancer, or any serious neurological disease. In other words, the scans are ordered on the basis of seeing what we might be there rather than to answer a very clear diagnostic question. So the best example of this is that if we think of someone who's, say, torn their cruciate ligament in their knee, okay, and because their symptoms point very much to that, and then the scan shows that they have torn their cruciate, then the scan matches the symptoms. and that scan will be deemed as appropriate. But if we were to scan a knee to just see what we can see and we have no idea what we're actually looking for, and as a result we have no idea if what we are then looking for is actually relevant, what if a scan was to show 3 different abnormalities? Which one of those 3 is correct, or are any of them correct? Simply put, unless we suspect something significant, a scan isn't appropriate. So scanning earlier or routinely without a specific question in mind is basically about as useful as asking a mechanic to fix your car without actually telling them what the problem is. And in the case of back pain specifically, early scans and routine scans, they don't recover any faster than people who don't have scans. And what is often different is what the scan shows. So large numbers of people are told maybe they have disc bulges or degeneration or wear and tear, even though these findings are also seen in people with no pain at all. And hence we can't say that this is the source of a person's pain. But this is very hard to explain to a patient once they've already been given a diagnosis. So an example of the ramifications of this early scanning. So in recent studies, we basically see that around 1 in 4 people who attend primary care, now primary care is your GP or say A&E. So 1 in 4 people who attend primary care with back pain still end up having some form of imaging or some form of a scan. This is despite the fact that guidance is very, very clear advising against these routine scans. Now, if we consider this as a cost, okay, and we say, right, in the UK, about 6 to 9% of the adult working population will visit their GP in a year because of back pain. Okay, so that's a huge one, 6 to 9% in 1 year. That's roughly 1 in every 10 adults will see their GP about back pain annually. Now, in the UK, that equates to a wide range, but anywhere between 3 to 7 million GP consultations a year for back pain. Now, as we stated before, despite the fact that the guidelines advise against routine imaging, of those 3 to 7 million, about 25% of them with low back pain will still receive some form of a scan. And as a rough ballpark figure, that's anywhere between 1 and 2 million people a year. So here we have a figure of 1 to 2 million people a year who will receive a scan of their back when it's indicated very clearly that it's of no benefit to them. Now, if you then consider the cost of that, so a back scan costs the NHS in the region of £90 to £120 per scan. An MRI is substantially more. So we're quickly talking about £100 to £200 million every year spent on scanning back pain alone. And this is despite the fact that guidelines indicate that this shouldn't be done. Now, these are ballpark figures, but they do highlight the scale of the issue. And that is why conversations like this are really important for both patients so they understand when scans are relevant, and for clinicians so they can make better decisions on scanning. And in a later episode, we will discuss why it is that clinicians still refer for scans, despite the fact that these guidelines would indicate that that shouldn't happen. Now, it is important to say that this does not mean that scans are useless. For example, in certain conditions where, say conservative management of back pain has failed, okay, or there's been a traumatic knee injury and there's suspected structural damage, a scan would be very much appropriate in this case, and it may indicate the need for maybe surgical or other invasive interventions. But the key point in these situations is that there's a clear clinical question, there's a clear reason for requesting the scan. And as a result, if we're asking a question, it means when we get the result of the scan, we're looking for a very specific answer rather than just looking for something. Now, as mentioned before, nowadays, it is increasingly common for people to be able to self-refer for scans. Historically, a person would be assessed by, say, a medical practitioner. They would form a potential diagnosis, and then if they saw appropriate, they then refer for a scan. And this scan will be requested to answer a specific question. But increasingly now, as I said, we're seeing the opposite, where people will obtain a scan first, and then they look to someone to interpret that scan afterwards. And this reversal and this shift does matter, because when a scan is performed without that clear clinical question, it's much more likely to identify findings that are completely irrelevant. And this creates a huge range of problems that we're about to discuss. Now, I want to be really honest here, okay, before we go any further. I know that for a lot of people listening, even though what we're saying might make perfect sense, and everyone's following so far, and that's all okay. And even though the research shows clearly that earlier routine scans, particularly on backs, shoulders and knees, don't usually lead to a better outcome or an easier diagnosis, there will still be a strong feeling among people of, yep, I see your point, but I still want a scan. Because when it's your body and you're the one that's feeling the pain, it feels very, very different. It feels personal, and it feels like, well, there has to be something physically wrong that a scan should be able to show. And even if the science or maybe a doctor or physio doesn't advise one, a person will still feel that having a scan would definitely help, and that basically if this is being denied, that it's only going to make them more anxious. And this reaction is completely understandable. But again, it highlights why having this conversation is so important, because what a patient feels is best for them is not always what's actually best for them. And it's our job to educate them on what is and what isn't. Now, when we think about why scans hold such a powerful place in terms of how we think about pain, part of that issue is just being human. So pain creates uncertainty, okay? And uncertainty feels threatening. Now, we spoke in the first episode about normal pain, and normal pain that follows a pattern, and normal pain that we're very used to decreases over time. But when something hurts and we don't know why it hurts, the natural instinct is to look for a concrete answer. And scans to people feel objective. It feels that, okay, they produce a picture, pictures feel definitive, and that's something we can see. And there's a common belief, often unspoken, that if I hurt, something has to be damaged. And this is what we discussed in the first episode. And if something is damaged, then a scan should show what it is. And if a scan shows something, then that must be the cause. Now, those assumptions, they make sense intuitively, but clinically they're often wrong. Now, there's also another important factor, and it's the desire for a label. And by a label, we don't mean we want to be labelled. What we mean is a label of a diagnosis. So a diagnosis can feel validating. So if we feel like there's proof that the pain is real, it can feel like the first step towards actually fixing the problem. So when a scan provides a name of something, so say a disc bulge or degeneration or a tear, people understandably attach meaning to that label. And the difficulty is that once a person forms a strong belief that a particular structure is, inverted commas, the problem, that belief can become very, very fixed and very hard to alter. Even if later information suggests that the finding may be incidental, it can be extremely hard to shift that narrative for a patient. And this isn't because patients are stubborn. It's because a belief was formed in a moment of vulnerability when they were in pain. And that's why the how scans are introduced and how they're ordered and how they're explained matters so much. And it also explains why simply telling someone your scan is normal or don't worry about that finding, it often doesn't work. Equally, a diagnosis given without proper context can be just as problematic. So, for example, being told, well, there was nothing serious found there except some degeneration in your lower back, without any explanation whatsoever of what degeneration actually means. So if it's not explained, people naturally try to make sense of that themselves. And often this is done by searching online or using AI, which again provides information, but it's not personal to the patient themselves, and often just turns out to be very generic information. So I suppose just to be open about this, I want to explain then what the research actually shows. So we've discussed why it is that people want scans, why it is they feel that the scan will add context to what their problem is. But what we're saying is they're not always appropriate. And it's our job as clinicians to explain to a patient when they are and when they aren't appropriate, even if a patient is very, very clear that they want a scan. So when we look at large groups of people who have had scans, a very clear pattern appears. The more people we scan and the more detailed the scans become, the more changes or abnormalities we find on the scan. And even in people who have no pain whatsoever. That means that seeing something on a scan doesn't automatically tell us if this is the cause of the symptoms. And this is where context becomes essential. So reassurance alone is rarely enough. So it's understanding that has to replace the fear. So this is one of the key points of the episode. And it's to make it clear to people that evidence is very consistent. Scans will show abnormalities. Scans will show changes. And scans will show wear and tear. But we still come back to this pivotal question. If the research tells us that these abnormalities are often present in people with no pain, how do we know if what we see in a scan is relevant? Now, one of the most influential pieces of research in this area is a large review that looked at MRI findings of the spine. And this was in people who had no history of back or neck pain at all, and they had no pain at any time during the study. Now, what they found was quite striking, but maybe wasn't overly unexpected. So we'll start with a bit of context first, okay, just on these labels and these diagnoses that we come across. So how many of the people listening here have heard the term disc degeneration or have been diagnosed with disc disease in the spine? Now, this would be common terminology. So the question is what is it? So we'll start with discs first, because discs in our spines seem to get a lot of attention, and potentially far more than they actually should. So the discs in our spine are mostly made of water, particularly when we're young. Now, over the course of a day, as we stand and as we move about, they lose small amounts of water, and the disc then compresses slightly as the day goes on. And this is why in the evening we're a little bit shorter than we are first thing in the morning. And when we lie down and we rest, the discs generally rehydrate and they go back to their normal thickness. And this is one of the reasons why we're generally stiffer in the morning in the back, because the discs are at their thickest, so our movement is actually reduced. Now, as we get older, these discs gradually hold less water and they naturally become thinner as life goes on. And this is a normal aging process. It's not a sign that something's broken. Now, disc degeneration describes normal age-related changes, and where the spinal discs gradually lose water content and height over a period of time. Now, on its own, there's a very weak link between disc degeneration and pain. However, once people are told that this diagnosis is present, it's very easy to interpret it as meaning this is the cause of your pain, even when that link is actually not clear at all. And it certainly doesn't help the fact that often it's presented to a patient as a diagnosis of degenerative disc disease. And in reality, it's not a disease at all. It's signs of disc degeneration that are very, very common across all adult age groups, including in young adults. And they become far more common as we get older. So large imaging studies have consistently shown that many people in their 20s, 40s and 60s have these changes of dehydrated or degenerated discs on an MRI, despite having no back pain at all. So seeing disc degeneration on a scan often tells us more about normal aging than it does about the cause of someone's pain. Now, if we stick with discs again, because again, they seem to gather a lot of attention, a diagnosis that gets even more attention again are disc bulges. Okay, now these are called several names. They're called herniated discs, bulging discs, prolapse discs, and my personal favourite and least accurate, a slip disc. Now, many people are told, or they have a pre-perceived notion, that a diagnosis of a disc issue represents a serious problem. Many associate them with disc issues where they may make contact with a nerve and assume that the disc issues always lead to the likes of sciatica or the equivalent in the neck. In truth, however, this isn't the case at all. And these two are also extremely common and are frequently seen in people with no back pain at all. So again, on these imaging studies, around 30% of people in their 20s have disc bulges with no pain. By the time we reach middle age, whatever we class as middle age, it's closer to half the population. And again, in the older age groups, the majority of people have disc bulges at that point in time. Now, these are people with no symptoms at all. And what many people don't realise is that disc bulges can change over time. So they often appear, they reduce, or they even disappear without any treatment, and often without any person even knowing that they were there in the first place. So aside from the fact that disc bulges do not reliably predict pain at all, many of them are temporary findings rather than a permanent damage. And that's one key feature, again, in the clinic we come across, is people that may have been diagnosed with disc bulges 10 years ago have the assumption that those disc bulges are still there because it was never explained to them that they come and they often go again. And these findings on scans are simple, normal variances that we all display. They can be better understood as age-related changes. And this is one of the clearest examples of why scans are not pain detectors. They show what is there, but they don't tell us whether or not it matters. And importantly, this pattern is not unique to the spine. The same thing shows up in most other joints in the body. So, for example, the knee. So scans of adults over the age of 40 show changes that sound serious. So, for instance, signs of arthritis were roughly seen in 20 to 40% of adults over the age of 40. Cartilage changes in around 40% of adults over the age of 40, and cartilage tears in close to 20%. And again, remember, this was done in studies of people with no knee pain at all. Now, if you imagine you have a simple knee pain, say after you've increased how much you've been running, and you're over the age of 40, you get a scan to see what you can see, not because there's definitive proof that there's something there we should be concerned about. There's a very real chance you're going to be told that you have arthritis and a meniscal tear. But the question is, are those findings actually causing your pain? Or are they common background changes that many people have anyway? And if we had scanned you prior to your pain starting, would the image have looked the exact same? So this is where the patient's story matters. And the message is consistent. Abnormalities in the body are normal. Pain is not. Scans for pain in joints are useful, but only if we have an idea of what we're looking for. And what about the term degeneration in general? So countless times in the clinic, a patient tells me that their pain is probably wear and tear, old age, or certainly in the part of the world I work, too many birthdays is a phrase that's used quite often. And they truly believe this. But in reality, what they're usually describing, whether by scan or just by their opinion, are just normal age-related structural changes, not a diagnosis of pain. Degeneration simply means a change over time. Now again, we know from large imaging studies that signs of degeneration in the spine commonly begin in early adulthood, so in our early 20s, and steadily increase throughout our age. And the same principle applies to the term osteoarthritis. So osteoarthritis is better understood as a description of how joints change over time, rather than a specific disease that automatically causes pain. So it's very common in joints like the knees, the hips, the hands and the feet. And importantly, research consistently shows that there's no direct relationship between how much osteoarthritis is seen in a scan and how much pain a person actually has. There's no chart whereby mild arthritis equals mild pain or severe arthritis equals severe pain. Some people with very advanced arthritis have little or no pain, and some people with minimal looking changes in their knee have severe pain. There is still so much we don't understand about osteoarthritis, but we know that the link of wearing of a joint and pain is not a direct link. But it's very hard to describe that to a patient. If they get a diagnosis of severe arthritis in say, their knee, for instance, and you're trying to explain to them that that doesn't actually match their symptoms, that their symptoms are actually related to something else, because a diagnosis holds a very, very powerful place. But the key message here is simple. Degenerative changes in the body are common. They increase with age, and they're often normal. And they only become clinically significant when they match a person's symptoms, examinations, findings, and their overall story. Without that context, the labels on these diagnoses actually tell us very little. Because if you think about it, if degeneration always caused pain, then there'd be huge proportions of the population with significant pain from their mid-20s onwards. But we know that this isn't the case. But again, the truth is, this is a very difficult message to cut through, and it challenges what most of us have grown up believing about our body. It challenges what many people have previously been told, and it challenges the idea that a scan should always provide a clear answer. But we must remember why we are talking about this. Why are scans important, and why are we spending this time talking about them? One of the main reasons is because in clinical practice, we often have people arrive who received a diagnosis recently, or more commonly, maybe several years earlier. And the longer they've sat with this diagnosis, the more entrenched it becomes. Now, that's fine if the diagnosis is accurate and relevant and they received a scan that is completely matched by their symptoms. But what if they didn't? And what if they were told in their, say, mid-30s that their knee had arthritis and a cartilage tear and they had to stop all weight-bearing activity? They're now 50. They've spent the last 15 years minding their knee, curtailing their physical activity and dramatically altering their lifestyle because of this diagnosis. What if somebody in their 40s was told they had degenerative disc disease and this was in their lower back and this was the source of their pain? And given this process of normal aging is irreversible, the patient is likely to believe that their pain is largely irreversible too. And again, this can then dramatically alter their lifestyle and their level of independence. And this is the whole point. I've had countless patients arrive in the clinic in situations where I've had to spend long periods of time trying to educate them on old scans, on old diagnoses, and whether or not they're actually relevant. And the reality is that the longer they have had this diagnosis, the harder it is to do that. This episode is to try and educate patients that scans have limitations. They're not the answer to your prayers in a lot of circumstances, and in fact, if presented wrong or misunderstood, they can be detrimental. And this is a really important point because it leads us to the next part of the problem. Even if everyone accepts that a scan is not always required and that abnormalities on scans are normal, someone still has to explain the scan results to the patient. And how they do this can be a huge issue. So, in general, images are read by radiologists and they then create a report. These reports are then interpreted again by either a consultant, a GP, or a physio. So before a patient ever hears an explanation, the information has already been passed through multiple human filters. Now, radiologists describe what they see on a scan. Their role is to document structural features as accurately as possible. That description is then interpreted by the clinician who requested a scan, and that interpretation is what guides the conversation with the patient. Different radiologists may use slightly different terms to describe the same finding, and those differences are not errors, they're just descriptive choices. The bigger issue is what happens next. So different clinicians can read the same report and place very different weight on what is written. Some may view one finding as insignificant and not related to a patient's symptoms, and others might find the same finding highly significant. And that difference in interpretation is what often shapes how the result is explained to a patient. And many of the terms used in the reports that we mentioned, such as disc bulges, degeneration, wear and tear, early arthritis, they're descriptive. They describe appearance. But if the descriptions are presented without linking it to patient's symptoms, we can get a completely different diagnosis and the patient can leave with a completely different outlook. This creates inconsistency. Now, it's rarely because of the picture itself, but of how the picture is interpreted. And I'm sure there are many people listening who can relate to this, appointments that maybe confuse them, anger them, or worry them. And in a later episode, we're going to dig deeper into conversations between clinicians and patients and discuss many of the pitfalls that occur. We as professionals need to try and gain consistency for the sake of the patients. And in scanning, this becomes extremely important when we talk about pain that maybe doesn't disappear in a normal time frame. So after everything we've discussed, where does this leave us on scans? In summary, scans are not good or bad. They're tools, they're extremely powerful tools, and when used for the right reasons, they can be essential. Scans are most helpful when they're being used to answer a specific question. Many common pain problems do not automatically need a scan. Now, being told don't need one doesn't mean you're being dismissed. It means the scan is unlikely to help. And when scans are done without clear reason, they often create more confusion and worry rather than better answers. So patients deserve to understand why a scan is unlikely to benefit them and what the clinician is basing that judgment on. And again, we will discuss in later episodes when this works and why it doesn't always work. But in summary, in episode 1, we looked at what is normal pain, why we feel it, and how pain behaves when the system is working in a protective and predictable way. In this episode, we built on that by looking at scans, what they're designed to show, and why they often don't explain pain in the way people expect. Now, together, these 2 episodes are building a foundation to understand how pain is produced and to understand what scans can and cannot tell us. In the next episode, we're going to start exploring what happens when pain no longer follows a normal pattern and why pain can persist even when tissues appear to have healed and scans don't provide any clear answers, as we maybe expect they might have. What happens in the body when pain persists and why? And this is where the next layer of understanding begins. Thank you for listening, and I'll talk to you soon.